guys probably talk your head off today because that's just kind of my style, about how I got here, and then a little bit about GI, or a lot about GI. And then lastly, I'm going to give you guys some tips and tricks that I kind of wish I had known back when I was applying for medical school. So again, my name is Rabia de Latour. I am a therapeutic endoscopist and gastroenterologist in New York City at NYU, and I am going to get started. All right, so just a little bit about me. I was born in Canada, and in Toronto specifically, and my family moved to Buffalo when I was about 7. I went to high school in Buffalo, in a suburb of Buffalo, and just in the bottom right-hand corner, you can see the Bills blown. And I really feel like this is our year for those of you who are football fans. I went to Cornell University for undergrad, where I majored in biological sciences and developmental sociology. And then I went to Stony Brook University for medical school. And then on the right, you can see actually someone shot a picture of my white coat ceremony, where I didn't realize how dressed up you were supposed to get and wore flip-flop sandals. And then graduation from medical school. And then at the bottom, you can see a picture of my 2 kids and my husband when I made them dress up. And you can see my little baby boy is really quite miserable in that photo. So I thought I'd share that. All right, after medical school, I went to NYU for my internal medicine residency. Then I stayed at NYU for my fellowship for gastroenterology. And then I did another year of fellowship because I'm a masochist and I just wanted the torture to go on forever and never wanted to get paid. So I did an extra year of advanced endoscopy fellowship at NYU. And that 1 year really changed the game for me, which I'm going to talk to you a lot about. At the bottom, you can see a picture on the left is from match day, when my best friend and I in the middle matched at our #1 choices. In the middle, bottom middle, is my first day of residency, and then the bottom right is my first day of fellowship. So I'm really happy that these were all captured in photos that I can reminisce. All right, in terms of how it's going, I am now an assistant professor of medicine at NYU. I stayed on where I trained, which is, has its pluses and minuses, which I'll talk to you guys about. And I'm the director of endoscopy at Bellevue Hospital, which is the oldest public hospital in the United States of America and has just a ton of history. In terms of my current role in academics, I am responsible for teaching students, residents, and training fellows in endoscopy, and I really enjoy that. So ultimately, when you graduate, you have to decide, do you want to do academics? Do you want to do private practice? And I'll talk to you about that a little bit more, but I really am happy with the fact that I chose academic medicine. All right, so before I go on, I just want to talk to you guys about this whole kind of side, even this session. I'm going to show you a lot of photos and it's going to look like everything is perfect, right? Because I'm only presenting to you my best self, or at least that's what I was supposed to do. But I'm a very real person and I'm going to be very honest with you guys. I've had lots of struggles. I had moments just, where you just break down in tears, throughout the entire cycle. I had moments where I thought I was going to fail. I had moments where I just didn't want to continue in the medical path for sure. And you just persevere. If it's meant for you, you'll persevere. And I'm going to talk to you guys about that more, but I just really want to point that out. A lot of people, especially with social media these days, present to you again their best foot and make it seem like everything is just fine and dandy, that they're not struggling, but it's real. And I know from when I was in undergrad, just, the interviews I was getting or not getting into my #1 choice for medical school, that it's really hard. So I wanted to just share with you guys that we all struggle. And if you see the bottom right-hand photo, that's me on my 28th birthday. Instead of being with my family or my friends, I was doing a 27-hour shift in the ICU, and the nurses were very sweet and got me a Domino's pizza and a brownie from Domino's, woohoo, and put a candle in it, even though it's probably breaking the rules. And I'm, smiling and I look happy, but I really would have preferred not to turn 28 in an ICU with really a lot of patients. So, it's not an easy path, but if it was easy, everybody would do it, right? So I just wanted to make that statement before I go on. All right, so why did I choose gastroenterology? I love procedures. So if you're someone who likes to work with your hands, it's a really great field. There's an insanely wide variety of pathology. There's liver disease, there is small bowel disease, there's cancer, there's just so many different things. Pancreas, you can be a specialist, subspecialist in any of those things. So there's just a huge variety within GI, and that was very attractive to me. Once you graduate from all of your training, GI is a field with competitive salary. I mentioned that, but it was not by any means a driving force. I don't think anything in medicine is you should do it for the money anymore, because it's just for the amount of years that you put in. It's not like other fields. So if you're only after the money, I don't think that you will be happy if you don't like the material and it's just for money. Truthfully, it's just not enough of a compensation to justify all those years unless you actually like it or love it. I'm very much a problem solver. So for me, gastroenterology, especially the procedural element, is perfect because you see an issue and you can either fix it or not fix it. Some people like to be in fields where you do a lot of thinking and mulling and focus on patients, in a longitudinal sense, where, like a chronic disease, for example, like rheumatology, you're with patients for a very, very long time, and you are with them, struggling with them and in it with them, trying different medications to see if it will help a lot of their conditions, or neurology, for example, where many conditions cannot be cured. So those are very longitudinal relationships where you may not be able to fix their problems necessarily, you might just be able to help. What I do with advanced endoscopy, if you have a problem, I can fix it. And to me, that's very rewarding. And there's no shame in being one or the other. It's just your personal preference, and getting to know yourself and deciding what's important to you is, I'd say, one of the biggest challenges of all of this training, just making sure you know yourself enough to do what's right for you. So I love problem solving and I love fixing things like mechanically. So for me, advanced endoscopy is perfect. Again, there's varying phenotypes, whether it's academics in GI, private practice in GI, it's not a monolith. So really you can do anything. And that is another attractive field of gastroenterology for me. And so on the right, you see I'm doing an ERCP, and you can see what is called a cholangiogram, which is basically me injecting contrast into the bile duct. And yeah, I don't know if you can see my pointer or not, probably not, but I'll use this pencil, the school pencil, and I don't know, I'll do an arrow, and then maybe you can see what I'm talking about, hopefully. Okay, so what exactly do I do? I did my gastroenterology training, my fellowship, so therefore I can do upper endoscopy and colonoscopy, which are the first two things listed. But because I did that extra year of training that I described to you guys, I now do a ton more procedures, including ERCP, which is basically a endoscopy that allows you to enter the bile duct and intervene on the bile duct. I'm going to talk more about that. I can do cholangioscopy, where I put a scope within my scope and actually stick my scope into the bile duct, and I can see directly inside the biliary tree and investigate things, biopsy things, and remove stones. I do EUS, which is endoscopic ultrasound. So it's when I have a probe at the end of my scope that's an ultrasound probe, so I can do ultrasound from within the gastrointestinal tract and see surrounding organs. I do bariatric endoscopy, which means I do weight loss endoscopy for patients. So a lot of patients have surgery to reduce the size of their stomach. I can sew their stomach to be smaller, and that allows me to help them lose weight without having to undergo a surgery. I do luminal stenting, which is done for strictures and specifically for cancer. So if you have a big colon cancer and you're not going to have surgery to have it removed because it's too far advanced, I can stent it open so that you can actually still allow your colon to not be obstructed. I do that in anywhere in the GI tract I can stent. I do complex polypectomy, which is when I take very large polyps out that are too large for general gastroenterologists to take out, and small bowel enteroscopy, which is basically scoping the small bowel. All right, in terms of upper endoscopy, I know you guys have had a few sessions with general gastroenterologists, so I'll just be brief. But basically, it's a thin, flexible scope that you insert into the mouth, and then you insert into the esophagus, the stomach, and the first part of the small intestine while the patient's lying on their left lateral side. On the left, bottom left, is a picture of a normal esophagus. In the middle and the bottom is a normal stomach, and on the right is a normal duodenum, which is the first part of the small intestine that we look at. So those are all just normal pictures. I also do colonoscopy. The scope for the colonoscopy is not only longer, but it's a little bit thicker and they're flexible. You start your colonoscopy in the anal canal and then you go up into the colon, and you can also evaluate the first part, the end of the small intestine, which is called the ileum. So the small intestine is your duodenum, your jejunum, and your ileum. And if you do a colonoscopy, you can enter the ileum and take a look at the last, 10 to 15 centimeters of that. The colon itself has 4 parts. There's the sigmoid colon, the descending colon, the transverse colon, and the ascending colon, and then it's truncated by the rectum and the cecum on either ends. And so that's just basically what you look at with a colonoscopy. And you can look, not only just do a diagnostic, but you can also do therapeutics in colonoscopy. You can take out big polyps, like I mentioned, you can stop bleeding, you can biopsy things. So, you do a lot with general gastroenterology. All right. In terms of endoscopic ultrasound, which is the next procedure I described that I do, it's basically a flexible scope, just like the upper endoscopy scope is, but you have this probe at the end, which is pictured in the blue picture, and that's an ultrasound probe. And so what it allows me to do is look at the organs that surround the stomach and the intestine and the esophagus. And through the wall of the stomach, I can use this scope to, under ultrasound guidance, stick needles through to do biopsies. I can diagnose stones. So on the right side, you see a mass, which is in the pancreas, and you see a needle coming out of the ultrasound probe, and it is taking a sample or tissue biopsy of that. Historically speaking, before endoscopic ultrasound was a thing, people were getting percutaneous biopsies, which means if you had a pancreas mass, someone was sticking a monster needle, usually under CT or computed tomography guidance, and sticking it through your skin into your pancreas. That is exquisitely painful. So now we can basically do it through the stomach, and the patient feels nothing. They wake up and they're completely fine. So it's minimally invasive, and it's just much better for patients to have it done this way. So that's endoscopic ultrasound. And again, you can ultrasound from really most of the GI tract. I can ultrasound things next to the esophagus. So I've biopsied mass that was next to the esophagus. You can biopsy things that are outside of the stomach, like the pancreas, the adrenal glands, the liver. You can also biopsy things that are adjacent to the small intestine right here on the picture on your left, like the head of the pancreas or big lymph nodes that you see. So it's a pretty neat procedure. I also do interventional EUS. That takes endoscopic ultrasound to the next level. So the picture that you see on your left is a pancreatic pseudocyst. So after a patient has a really bad bout of pancreatitis, which is an inflammation of the pancreas, that can happen from drinking too much alcohol, it can happen from gallstones, it can happen from medications. When the pancreas gets inflamed, what it does is it traps fluid around it, and it loves to just like third space fluid all around it. And sometimes that fluid forms basically a little balloon and just sits there in your tummy, and people can have pain from it. They can have an obstruction of their GI tract from it because it's so big, it can compress a small bowel. It can also get infected, in which case they get pretty sick. I am able to, with my endoscopic ultrasound probe, find that thing through the stomach wall and stick a stent from my stomach into, not mine, but the patient's, into this fluid collection that has like a nice orange like rind around it, and allow it to drain. And that basically prevents a patient from having to have a huge surgery or a drain sticking out of their belly. And here's a video of one of the ones I did a couple months ago. After I drained it, all this pus just came out, and it was really so beautiful to me because this stent, which is like a double barrel stent, just allowed it to just come flowing out, all the pus. It was in a patient who had an infected pseudocyst. And again, like literally 5 years ago, these patients would have had to have either surgery or percutaneous drain, but this stent has just been really awesome and allowing us to drain it. So it's really nice to be able to do that for them. And then that stent comes out in about 1 to 2 months, and ideally that fluid collection is completely resorbed. So it's pretty neat. Okay, so in the same vein, there is another procedure that we do with EUS. It's when patients have an infected gallbladder and they're too sick for surgery, or they're too old, or they have too many comorbidities. We can do the same thing with that stent, basically creating a tract for drainage from the small intestine, which is right past the stomach, into the gallbladder. And that's another way. If you see on the right side, the animated picture shows the stent allowing, because anytime you have any infection in your body, the number one thing you need is drainage, right? So antibiotics don't always permeate a abscess, which has like a rind on it. So you need to drain it somehow. You need to get that out, or that infection will stay there and the patient can get really sick. So drainage in any capacity, whether it's taking out the gallbladder surgically in this case, or draining it this way, or having a percutaneous drain. This is just better for the patient because then they don't usually feel it and they don't go home with a drain coming out of their stomach. So it's just a really nice additional procedure that we're able to do. All right, so this slide is probably one of my favorite slides that I use for teaching, and it's going to be a slide that I'm going to use. It's a summary slide of basically all the things that I deal with when it comes to stone disease. So I'm in the business of taking stones out of people's biliary tree. It's one of the main things I do using ERCP, which is the next procedure I'm going to talk about. But before I talk about it, I want to explain basically the anatomy of what I'm talking about. So this picture is the very end of the stomach and the duodenum. When you have your stomach, so you have esophagus and stomach and then duodenum. The duodenum is what makes up that C right there. It's a small intestine, the first part of the small intestine. In the second portion of your duodenum, because each of the pieces of bowel have like portions that allow us to define them, and it's based on their anatomic location. In the duodenum, you have the entrance to your bile duct. Your bile duct, I'm not sure if you guys can see my arrow, but I'm going to, let me do
We can see the arrow.
Okay, great. Oh, I'm so happy. Okay, so right here in the second portion of your duodenum, you can see the entrance of the bile duct into the duodenum. And what that does is it allows bile that's flowing from the liver, as you guys know, to drain into the small intestine to help you digest fats, right? And the gallbladder is just a storage sac for bile. So that's the anatomy. On this little branch right here, which they're not showing, this is a pancreatic duct. So the pancreatic duct, which drains the pancreas, and that is all the enzymes that your pancreas secretes to help you digest, they basically all dump into the small intestine. All right, so when I'm doing my procedures with a biliary tree, which is like a big proportion of the procedures I do, I am taking a separate scope that's called a side viewer scope or a duodenoscope, and I'm putting it into the second portion of the small intestine, and I'm using wires and other tools to get into this pinhole, which is the opening to the biliary tree. And I basically go up here and then I can do interventions. I can place stents, I can remove stones, I can place, another scope within this to look, and that's called cholangioscopy. And I can just do interventions in the bile duct. So what sort of interventions do I need to do? That's based on all the different disease processes. So this picture is great because it summarizes almost all the disease processes that can happen here. So number one is forming stones. Not everyone forms stones, but people who do form stones, they can be completely asymptomatic. And hold on a second, I'm just going to exit out of this poll if it lets me. My laser won't let me. Oh goodness. Hold on one second, guys. I have to do an arrow so I can get out of this. Okay, so I'm gonna go back to my laser pointer. All right, so number one, if you form gallstones, which not everyone does, in 75% of people, they're just asymptomatic. You'll never know you have them unless you have a CAT scan for something else. They just sit in your gallbladder and they'll do nothing for the rest of your life, and that's fine. Number two is basically when you have a stone that intermittently comes and gets jammed into the outlet of the gallbladder into the bile duct, which is called the cystic duct, because this is the gallbladder is duct into the bile duct, it's called the cystic duct. If a stone comes and intermittently jams in here, like every time you eat fatty food, that's called biliary colic. And it's something that a patient will come in and say, once in a while, every time I eat fatty foods, I get right upper quadrant pain, but then it goes away after like a couple minutes or an hour. And that's called biliary colic. So 20% of people with stones will have that. When a stone sits in the cystic duct and gets jammed and does not come out, that will cause an obstruction and usually cause acute cholecystitis, which is an inflammation of the gallbladder. So you have asymptomatic stones, intermittent stone coming in and out, which is called biliary colic, and 3 is when it's totally jammed in there and then this gallbladder has no way for it to drain anymore. You're going to get acute cholecystitis. Okay, I'm going to skip 4 for a second and talk about number 5. When a stone comes into the biliary tree here, the bile duct specifically, this is called the common bile duct. That is a problem because not only do you have to absolutely remove it anytime it's in here, and that's what I do with ERCP, but if a stone gets stuck in here and it's not just free flowing, you're at risk for an infection. that infection is called cholangitis. Cholangitis is life-threatening. It is an emergency in my field, and you have to intervene and get that stone out immediately. So the reason why this happens is the duodenum and the entire GI tract are dirty, right? Our microbiome live there, and your microbiome is a beautiful thing, and your gut is, you and your gut are full of bacteria. So the duodenum is like a very dirty place, but that's great, right? We don't mind that. The biliary tree is sterile. There should be no bacteria in here, but from time to time, bacteria will reflux back in. And if there's a stone, that serves as kind of like a foreign body that the bacteria can just latch onto and stay there. If the stone then also obstructs, what it's doing is allowing bacteria to duplicate and just have free reign in the sterile field. And that's what causes the very serious infection. So in terms of terminology, again, we have stones in the gallbladder alone, which is just called cholelithiasis. You have a stone that obstructs here, which is called acute cholecystitis. You have an infection with a stone or obstruction here that's called cholangitis. And then lastly, if there's just a stone in the bile duct and it's not infected, it's called choledocholithiasis. So I know that's like a lot of words, and it's like, just all these CHs and Ds, and you're just like, what the heck? But this is a very important distinction. Cholelithiasis, stone. Cholecystitis, stone plus inflammation or infection of the gallbladder. Choledocholithiasis is stone in the common bile duct without any infection, and cholangitis is with the infection. Number 4 I skipped, and that is called Moritzi syndrome. It's when a stone is so impacted in the cystic duct and big that it actually causes compression of the bile duct, just because it's like taking up so much space, but it's not truly in the bile duct. So that's called Moritzi syndrome. And then last but not least, sometimes you can have stones that are so big in the gallbladder that they actually erode into the small intestine and form basically a tract. And that's called Bouveret syndrome. And it's quite rare, but it's pretty cool when you see it. Okay. All right, so we talked about ascending cholangitis, and again, this is one of our emergencies that we must go in and treat and decompress the bile duct. So basically what you have is an obstruction in bile flow, usually from a stone, bile stasis, like I mentioned, the bile is not able to flow, a bacterial superinfection of the stagnant bile because it's not flowing out, and what it results in is early bacteremia. So I learned this in medical school. I'm not sure if any of you guys have taken like a physiology class or something, medical physiology, but sometimes they teach this in there. There's signs, clinical symptoms that you need to know in med school for cholangitis. There's Charcot's triad, which is 3 signs that you have cholangitis. It's fever, right upper quadrant pain, and jaundice. And then there's Raynaud's pentad, when you have hypotension and mental confusion on top of it. And that suggests that the patient is septic, meaning they have bacterial infection that's basically in their blood and spread everywhere. If left untreated and severe, patients can develop abscesses in their liver from the infection going so high up, and they can die. So it's very important that we go in immediately and treat these patients, usually in the middle of the night. All right, so we talked about biliary colic, which is just that stone intermittently going into your cystic duct, and the treatment for that is take your gallbladder out. Then we talked about acute cholecystitis, which is an infection of the gallbladder because that stone is stuck in the cystic duct. And for that, you take your gallbladder out. It's not working. Okay. All right. Next, you have choledocholithiasis, which is just a stone in the bile duct, but it's not an infection. And the way you treat that is an ERCP, which I'm going to talk about next. And then you have them take the gallbladder out so that the gallbladder can't house any more stones. And just FYI, cholecystectomy is a removal of the gallbladder. And then last but not least, you have cholangitis, which is that infection I spoke about with obstruction of the bile duct. And the treatment is emergency ERCP with stone removal and antibiotics. And then at a later point, they should have their gallbladder removed. Okay, so let's talk about ERCP. ERCP is an endoscopic retrograde cholangiopancreatography, and that's what I was discussing earlier. So I take my scope, I put it in the esophagus, the stomach, and then the small intestine. I come to the second portion of the small intestine, and then I use different tools to try to get a wire and a tome, which is the tool I use to get the wire in, into the bile duct. Now, this is a side viewing scope, so it's not forward viewing like the upper endoscopy and the colonoscopy. It's side viewing, meaning it will just face this area. So it's a specialized scope made for this procedure. And one of the reasons why it's so tough to do this procedure and why you need extra training is because the opening for the bile duct is basically like right next to the opening to the pancreatic duct. It's like 2 roads converging into a highway. And so anytime you're trying to get into the bile duct, if you don't do this procedure properly, you can get right into the pancreatic duct and cause pancreatitis. And in medical school, you're going to learn a ton about one of the causes of pancreatitis is post-ERCP pancreatitis. And I didn't really understand this for a while until I was a GI fellow. So I want to explain it to you now. The reason is because, again, these are so close to each other, literally millimeter apart, that it's very hard unless you're technically skilled to get the wire straight into the bile duct every single time. So here is a picture from one of my procedures. You can see my scope right here. And then what you can't see is my tome. Something else I should explain. The endoscopy part you're visualizing directly, just like the pictures I showed you of the stomach and the esophagus and the small intestine. When I am in the bile duct, I'm doing things under live x-ray because, again, there is a scope that exists that's really tiny to get in here, but unless this bile duct is dilated to more than a centimeter, which is usually less than 5 millimeters, you can't use that scope. So the majority of time you're doing ERCP, after you've gotten your scope to the second portion of the duodenum, you then are doing everything else under live x-ray and using contrast. So I get up to the major papilla, which is what it's called, this opening, or the ampulla of Otter, and I put my tools up here and I'm doing it all under live x-ray or fluoroscopy to make sure they're in the right place. So here you can see my wire is right there. And I have another tool over the wire that's allowing me to inject contrast and basically light up the entire tree. And then here as well, you can see the gallbladder that's like coming down. Here's a cystic duct and the gallbladder is a big sac and it contains just a ton of stones in this patient. It looks like a gumball machine. Okay. So these are a few pictures of my ERCP. The tool I talked about that I use, I put through my scope to get into the bile duct is here. You can see how tiny this is. My husband asked me what I do for ERCP, and I basically told him that from like 10 feet away, I'm trying to get a wire and a tool that's like 2 millimeters in size into a pinhole that's like a few millimeters. This is all really tiny and takes a lot of stability and endoscopic, like tactile skill. So if that's something that you like to do and you don't want to go into surgery because, you know, surgeons aren't always like nice, you can do GI and be very happy and still do, you know, get your kicks in terms of like doing procedures like this, which I really love. I can say that my sister's a surgeon and she's sometimes mean to me. So that's why I'm allowed to say that. So it's okay. All right, so the bottom picture is here. This is a stent I placed into the biliary tree, and you can see, I'm going to get back my laser pointer. You can see right here that it's a tightening because this patient had a bile duct cancer that basically narrowed it. And so the stent was allowing bile to still drain in the patient with cancer, and it was just tight there. This is after I placed a stent. You see the gush of bile because it had all been backed up in the liver because of this obstruction. And then again is the same picture of my cholangiogram here, which is a live x-ray when I was doing an ERCP a couple weeks ago. Okay, so in terms of ERCP, again, this is what a normal biliary tree looks like. This is not my picture. This is from the internet. And you can see this person basically injected contrast and lit up the entire biliary tree. But unfortunately, they lit up contrast and lit up the pancreatic duct as well, which is not great because the pancreas is very irritable and you don't want to inject contrast into the pancreatic duct unless you absolutely have to, because you can cause pancreatitis. Okay, so this is what a normal ampulla, that pinhole I was talking about when I'm in the second portion of the duodenum, you find this little thing, looks like a little nipple, and you have to basically get your tools into this orifice, and you have to aim up and to the left, because if you go straight, which is what's easiest to do, you're gonna end up in the pancreatic duct. So it's a really, really tough procedure. Once you're in, you have to make an incision up here, and the tool that is called the sphincterotome that you use to get in is what you actually use to make this cut, because it's connected to cautery, and you just zip up, kind of in an 11 o'clock position, because your goal is to cut this muscle, the sphincter of Oddi, because you want to basically cut that sphincter so that bile can flow easily. And if there's a stone in there, it's not going to come out of the pinhole. So you're basically cutting to allow the stone to come out or stents to go in, whatever you're doing for your intervention. This is after the sphincterotomy. You're doing a balloon sweep afterwards. You basically go in with another tool. You go up into the bile duct, you inflate the balloon, and then you drag it down. And with it usually comes stones or whatever debris is stuck in the bile duct. Here's another beautiful picture, cholangiogram of the live x-ray we use. This is a cystic duct stump because the patient already had a cholecystectomy. You can tell because there's clips there. And then the rest of the biliary tree is just lit up really nicely there with contrast. Here's a patient with a cholangiogram who has a bunch of stones in their gallbladder, and it just, again, looks like a gumball machine, and the rest of the biliary tree looks pretty normal. Let's see what else. This is a patient who in their biliary tree, in their actual common bile duct, you can see a bunch of stones. And so on the cholangiogram, which is again the live x-ray that you use, you can see the stones, and they're called filling defects because again, you're not directly visualizing it, it's under x-ray, but you can tell pretty clearly that those are stones. All right, so when you do your balloon sweep, you pull out stones out of the bile duct. Basically, it's called sweeping them out. You're just sweeping this stuff out. You can use a balloon to do it when you inflate the balloon above and drag it down, or you can use baskets, which actually go and capture the stones. So that's ERCP, and we can talk more if you guys have questions later. Other procedures I do, complex polypectomy, one of my favorite things to do. So in patients in their colons who develop polyps, you know, most of them are small and they're easy to take out, and general gastroenterologists take out routine polyps all the time. When polyps start to get larger, like larger than 2 centimeters, it should require someone who is more comfortable with complex polypectomy because when you have polyps like this, as you can see in this photo, this is a polyp I took out, I think a couple of weeks ago, and they're larger in size, the worst thing you can do is take out part of it and leave tiny little tidbits, because then that patient has a higher risk of developing cancer. These polyps are pre-malignant usually, meaning precancerous. So you want to take them out, especially if the patient has multiple, or you know, if they have a family history of colon cancer. You just want to make sure in anybody who see a polyp this size that you take it out completely. Ideally, you take it out in one piece, because they've studied people who have had these polyps, and when you take it out in one piece versus piecemeal or in like tiny chunks, the rate of recurrence is much higher in piecemeal resections than it is in en bloc or one piece. So here's a big polyp that I saw. It had all these, looked like a flower really. Then I looked at it under NBI, which is narrowband imaging, to really get a nice look at the actual pit pattern, which is what we call it, for us to see whether or not it looks malignant or just pre-malignant. And then I injected basically a lifting agent underneath it. It's kind of like a gel that really makes it blossom. And then I just took it out. So you basically lasso it using this snare, and then the snare is connected to a cautery source, and you can just basically excise it. And again, these polyps in areas of the country where advanced endoscopists may not be able to help, sometimes they have to go to surgery. So imagine having to have a piece of your colon removed when it could just easily be taken out endoscopically. And I think that's one of the best things about advanced endoscopy, is you're saving people from having to go through a lot of invasive interventions, specifically surgery. So this was a really nice one. And then once you take it out, you we'll repeat the colonoscopy at an interval based on what you did and decide whether or not there's a recurrence. So this one came out really nicely en bloc. Then we send it to the pathologist. They look at it under a microscope and they tell you, hey, you took this out and there are clear margins, meaning the bottom of your sample that you sent them had no pre-malignant tissue. It was clear, it was normal tissue. And so you don't need to go back in a few months and look, because you took out the whole thing entirely, and you should just repeat it in like 3 years, the colonoscopy. All right, next thing I do, I feel like, oh my God, I do so much and I'm talking so much. All right, I do bariatric endoscopy, which I was discussing earlier. Bariatric endoscopy is a fairly new field. It's one of the coolest things I have ever seen in GI, and I just love it. So basically, patients who are overweight or obese, which is 70% of the United States population, sadly, can undergo surgery to have the size of their stomach decrease so that they feel fuller earlier and they eat less, and so they'll lose weight. There's, you know, a couple different types of surgery you can do for that. You can have a sleeve gastrectomy, which is just basically making the stomach into kind of like a sleeve. It's like skinnier. You're basically removing like longitudinally a part of the stomach. There's also Roux-en-Y gastric bypass, which you basically take the stomach and you cut it so that it's like a little pouch left, and then you just glom on small intestine onto it so that you basically not resected, but excluded a big portion of the stomach. Those procedures are awesome for people who need them, who have a BMI or comorbidities plus elevated BMI, and they warrant it, and they do wonders. People have their diabetes reversed, they have their high cholesterol reversed. It really helps people. They're phenomenal surgeries. But there are some people who are not heavy enough to qualify for these surgeries, but yet they have like a comorbidity or an issue, right? So their BMI is on the lower end, they're still overweight or obese, but it's on the lower end and they have an issue like chronic back pain. Those patients will get sent to me, and I can actually sew inside their stomach to make it smaller so that they feel fuller earlier. And this video, if it works, I'm not sure it will work. My video's not working. Hold on one second, guys. There you go. This is a video of my suturing device that I use to basically plicate the stomach, and I take full thickness bites and basically sew along the stomach and just create essentially a sleeve endoscopically. So all inside. The patient has no scars. They have no surgical abdominal scars, anything. They kind of wake up with like a little bit of pain, but they usually go to the hospital, go home from the hospital that day or the following day. So this is just a video of me taking one bite, and then I take another bite and another bite, and I basically do U-shaped sutures in a line, and then I do another one, and then I do another one, and then I do another one until the stomach is basically a skinny little sleeve, just like it is with the surgery. This is another one that I do in patients who have had that surgery I talked to you about called the Roux-en-Y gastric bypass, where their stomach is basically excluded and they have an anastomosis, which is an artificial connection between their stomach and their small intestine. This is supposed to be a small pinhole so that they basically fill up their stomach and feel full. In patients who've had surgery a few years ago, they start to essentially really dilate up. And another procedure I do is called a TOR, where I basically do a suture in a purse string manner and I tighten that hole down. So that's a hole before on the top and the hole on the bottom after I finish suturing it. That's one I did on Monday. So that's another awesome procedure called the TOR procedure. But endoscopic bariatric endoscopy is just a really cool field and burgeoning and going to grow really exponentially in the next couple of years too. So it's awesome. Okay. All right, a couple more procedures. So luminal stenting is, again, awesome. It's another thing that you can do in advanced endoscopy. On the right, you can see the red arrow pointing to what's called an apple core lesion, and that's seen when you have a colon cancer or a cancer really anywhere in the GI luminal tract, where it just basically takes up space and starts to cause a narrowing, and the lumen that's left looks like an apple core. You can see it on the right with contrast, on the left without contrast. And whenever you see that and the patient has symptoms of obstruction and they're not going to undergo surgery to remove the portion that the cancer is involving, we go in and place a stent. So this is a stent that I placed actually in the esophagus up here. And this is what it looks like after the stent is placed, because it's like a mesh basically, and the tissue all comes in around the mesh of the stent, but at least you have an opening then. So it's really nice to help patients like that, again, so they don't have to have massive surgeries just for diversion if they're not going to have surgery that's going to treat them of their cancer. So, you know, again, just another example of like being able to help. Let me see, I have a poll on my way again. Okay, perfect. All right, so next, I want to talk a little bit about other things I've done. So one of the things that I advise any of my mentees is, and I'm going to talk about this in a few minutes when I go over tips, but doing something that sets you apart. When I was an undergrad at Cornell, I was nothing unique. I had good grades, I had a good MCAT score, but I wasn't competitive for medical school because I was just so basic, to be completely honest with you. There were a million people just like me applying. I didn't do enough to set myself apart, and that's one of my regrets. I wasn't an athlete. I, was a bio major, and I wish I had done more or had been guided more to do something that was a little bit unique, even if it's just like volunteerism or something. So keeping that in mind, and I'm very happy that I went to Stony Brook, but to be completely honest with you, it's the only medical school I got into, and I had a really good MCAT score and a 3.7 GPA from Cornell. So I'm like, why didn't I get any more interviews? But it's okay, I am where I am now, but it's just something to keep in mind. Again, I'm very honest, and I'll be honest with anyone who asks me questions, but it wasn't easy. I was a little bit disappointed. I wish I'd gotten into more schools or had more options, but again, I'm very appreciative for that opportunity. So when I was in medical school, I decided that not only did I want to do something that set me apart, but I want to do something I loved. So I love traveling and I love learning about different cultures. So I decided to pursue my interest in global health, and had the opportunity, I got a scholarship to go and work at a hospital in Turkey. So in the bottom, you can see all my students. I randomly got assigned to teach cardiology there for a couple of months. So I taught all of these medical students in Istanbul about EKGs, and they will never forget it because I basically taught them like everything I knew about reading EKGs, and it was pretty awesome. I was an internal medicine resident at this time. When I was in medical school, I went to Kerala, which is this picture here, and I worked at a cancer hospital for a couple of months. And again, that was just like one of the coolest opportunities I've ever had. And I highly recommend, if you have the opportunity and you don't have, you know, family obligations in the States that you, like if you're able to basically travel while you can and try to get some global health experience under your belt, because it's great to see how other countries operate and practice medicine. All right, next thing is research. I have a lot of research now. Did I have a lot of research as an undergrad? No. Did I sign up to work in a research lab with rats and completely hate it and fall asleep like the 2 times I went? Yes. Did the person who was the PI there hate my guts and think that I was a complete failure? Yes. And it's okay. I realize I hate bench research with a fiery passion, and I love clinical research, but it was a learning lesson, right? And I definitely was a disappointment to that person. I definitely will never ask that person for a letter of recommendation, nor did I, but, you know, or list them on my CV because they had nothing good to say about me, but it was a learning experience. So to set yourself apart, you need to do research. Research is one of the things that people who are interviewing you can hang their hat on in terms of, I hired this person because not only were they good personality, easy to get along with, and hardworking, but they did all this research to prove that their clinical acumen extended beyond just like patient care. Not saying that patient care isn't like the most important thing, but if you're in academics, it's very important to set yourself apart and do research. All right, next, media. I love being a medical correspondent. I have contributed to like every newspaper, magazine known to man. I'm a regular correspondent on Fox 5 in New York, and it's really kind of my favorite thing. I'm forced to like think on my feet when I'm doing live television. They ask me to talk about topics that I have like no knowledge of, and you just have to be an expert, but it's really fun. And it's something sort of like a hobby for me that I enjoy because I don't want to just do patient care all the time. I think having a wide variety of your interests within medicine is important, and also it sets you apart. So, you know, here are just a few clips. Like I've been in HuffPost, Cosmo, I'm on the medical review board for Self Magazine. This was one of my particular favorites, was one of my first articles when I was like taking anything I got was, we asked a gastroenterologist if hot Cheetos can give you a stomach ulcer. That was really fun for me, and I had to talk about Lil Xan. I didn't even know who he was, but now I do. And then here's a clip where I'm talking about, you know, cold virus curing bladder cancer. And again, I'm not a urologist, I'm a gastroenterologist, but what you have to do to prepare for these is really just make sure that you're well read and you read the evidence and assess the evidence. And once you can do that and feel comfortable doing that, and you're happy to talk in front of a camera, like these outlets really just love having doctors on. You know, obviously with coronavirus, you guys have seen a lot of doctors on TV, and I've been doing medical correspondent for about like 4 years now, but it was really awesome to see how much love doctors were getting and how much of a voice and a platform they had, sadly in the setting of a pandemic, but it's just nice to see that. It was great to see the doctors coming forward and sharing evidence and encouraging people to get vaccinated and whatnot. Okay, next is committee work. So in academics, if you want to get promoted, you have to have some sort of national recognition. So whatever field you're in, for me, it's gastroenterology, you need to join the committee. So ACG is the American College of Gastroenterology, ASG is the American Society of Gastrointestinal Endoscopy, and then there's a New York Society as well. So if you do society work and get involved in some capacity, it's very important for promotion. Social media. So here's my shameless plug. I'm so bad at social media. I wish I was better. I need help. If any of you are social media mavens, help me. Follow me at Instagram. I'm at Dr. de Latour. I joined Twitter last night and I don't even know how to tweet, but my friends are trying to teach me. I'm like a total embarrassment. On the right is a doctor who I met named Dr. Mike, who has like 4 million followers on Instagram and like, I don't know, 10 million or something on YouTube. He was a really nice guy, but I just was like, how is this possible? Like, how many people want to listen to a doctor? But he's really good at it. He's my social media inspiration. So if any of you want to help me, just, you know, contact me afterwards. Oh yeah, and follow me because I need followers. I'm a lamo and I need followers. So anyways. All right, so a few tips before we run out of time. When you are applying for medical school or residency or fellowship or anything, even a job, do something to set yourself apart. Again, these are some of my global health experiences. Volunteer, and if you volunteer, commit yourself to actually going all the way, and no one should ever dismiss you. If you have a cause that you care about, start an organization. There's no reason why you can't be that person. Young people, younger and younger people are doing amazing things all the time. If you play an instrument or you have anything else that sets you apart, shout it from the rooftops and make sure that the people who are reading your application know about that, and really buff it up and make it huge on your application and in real life. So that's my tip. Number two, make time for what matters, and that's work-life balance. I'm a mom of two. My family is my entire life. You'll never hear from my kids like I miss something of theirs, because I made sure to pick a job where I had time for them, and I when they hired me, I said, if you need someone who's going to be working every single weekend, that's not me, because my priority is my family. So, that's very important. And, you see a picture of me here with my friends. I was pregnant with my daughter at the time. We went to a march, and I love to travel. So, just make time for what matters. And it's a balance. It shouldn't be too much in either direction. You shouldn't be, leaving work early before your work is done to go and hang out with friends. That's not work-life balance. It's about finding a steady pace that works for you and for your family. Something I want to talk about in terms of, how much growth medicine has made in terms of representation. This still has a lot to go. Medical school is now about 50-50 in terms of male-female breakdown. Gastroenterology fellows are still 30% female and 70% male. And advanced endoscopy fellows, which is what I do, in 2019, 9 out of 70 were female. And so I work in an overwhelmingly male field of work. But one of the reasons is because women, or what they think is, women are afraid to use fluoroscopy, like the live x-ray, especially women of childbearing years. You can work around that. You can say, while I'm pregnant, I'm not doing fluoro, or I just did a research project basically studying fluoro exposure during my pregnancy, because I did fluoro while I was pregnant with like tons of lead protective gear, and it's okay. I just want to share this because I was talking about work-life balance, and it is possible to have a family and do awesome work. Just don't. This is why representation matters so much. If you don't see anybody who's like you doing it, you'll never envision yourself in those shoes unless you're just a very innovative thinker. And so just know that there's people like me. I didn't have any female mentors until very late in the game. A young female who I was working with really just inspired me that, what, you can do all this. You can do advanced endoscopy, you can have kids, and you can just make it work for you. And this is a picture of me. I was 9 months pregnant with my daughter, and my co-fellows and I just at work. You can do it all. Just believe in yourself, which is what I tell my daughter. Just believe in yourself and you can do it all. And that goes into mentorship. You need to find an effective mentor, someone who you click with, someone who understands you, and someone who's invested in you and not just, advancing their own career. They have to be someone who maybe has proven to be a good mentor in the past to someone else. And once you find that person, glom onto them and prove your worth. No one is going to, stay up late and lose sleep over helping you if you don't meet them halfway. You have to prove your worth in terms of asking for projects and then delivering. You don't want to be the one making excuses, like you signed up for a research project and you just haven't collected data by the deadline, and you're saying, oh, something happened to me and this and this and this and this. No one wants excuses. Just get it done if it's important to you, and then ask for more projects. And that's how you develop like a relationship with someone and a good mentor. And on the flip side, don't bite off more than you can chew. If someone asks you, hey, are you interested in this project, and you're not interested, and you have 20 other things, but you don't want to be someone who says no, you have to be honest. The worst thing you can do is say yes and then not deliver. I have done that before, and I'm speaking from absolute experience. I wanted to be a cardiologist before I went into GI. I signed up for research projects with cardiologists, and now when I see them in the hospital, they avoid eye contact with me because they're like, oh yeah, who's that girl who totally dropped the ball? So again, don't be that person. I was that person. Again, thankfully it worked out, but if you can avoid it, learn from me. All right, another thing for medicine in general, and I know we're really running low on time, so I'm going to talk fast for these tips. Do it for the right reasons. I mentioned this earlier. You really need to pick a field that you enjoy, not one that you think will just look good on paper. I have a friend who just felt like, again, this is stereotypical and I probably shouldn't say this, but I'm going to. He felt like, I want to be an orthopedic surgeon because I just love it. And he wanted to be like a macho guy and fit in with that crew. And he applied and matched and he just absolutely hated it. And it just wasn't for him. And he was miserable and he ended up switching to anesthesiology, which is wonderful. And now he's like euphoric and so happy. Make sure you do something for the right reasons. Make sure you enjoy it. That's what medical school is for. That's what, rotating on different services is for. And at the end of the day, nothing is final. You can always switch. I have a friend who did an entire internal medicine residency. She was an internal medicine attending, and then she went back after 3 years and did a surgery residency and was an intern all over again. And it was very hard, but that's what she wanted to do. So follow your heart. All right, get to know yourself along this journey. It's really easy to go through life just like wishing away, like, oh, I can't wait till I'm done with undergrad. I can't wait till I'm done with medical school. I can't wait till I'm done with internal residency, fellowship, whatever it is. And just like kind of living your life, like just wishing away, like to the next point. I just can't wait till I'm an attending. But like nothing ends when you're an attending. It's still competitive. It's still cutthroat at times. I still get stressed out. I still feel like, oh gosh, I'm not doing enough. I'm not good enough. Even though on paper, undergrad me would have been so proud of where I am now. I still feel a lot of pressure to like perform and do more research. It never ends. But along the way, pay attention to yourself and get to know yourself and get to know what your attributes are, what you're good at. Are you a procedure person? Are you someone who is really good with your hands, or are you terrible at that stuff? Because if you ask yourself those questions along the way, it'll be much easier for you to decide what is right for you and what you should be doing, so you don't make any wrong decisions for yourself, because these are really big decisions that you're being asked to make in the midst of very stressful times for you, like, taking step 1 or step 2 or your MCAT, and then being asked like, okay, well, what residency do you want to do, for what field do you want to pick for the rest of your life? It's hard. So ask yourself these questions along the way and get to know yourself. While you're doing it, foster great relationships. These pictures are from my wedding, and these are my best friends from med school on the left, in the middle, and on the right are my close friends from residency. It's just really important. You're all in it together, and it makes some of the torture so much easier to deal with if you're doing it with good people. So really, again, some of these closest friends in my entire life. So I'm very happy. Network kind of goes hand in hand with like mentorship. When you're networking with people, it's very important to do it organically. These are things that I never really learned growing up. I'm a child of immigrants who worked very hard to be in this country, but, and they gave me very good life lessons, but it's not something that they sat down and taught me, like, this is how you network with people, because it just wasn't a priority for them, And so when you're networking with people, meet them, ask them for advice. Don't ask for favors right off the cuff. You don't want to meet someone, work with them for a week, and then say, oh, will you write me a letter of recommendation? You have to foster relationships, get to know people, do nice things for them, and then they'll remember you when it's time for an opportunity or something good. And remind them of your strong suits. Tell people what you're doing and share with them, and if you work hard for them, they'll remember you. Only 2 more tips, I swear. I know we're out of time. Follow through on your promises. If you sign up for a project, finish it. If you volunteer for an organization, commitments should be at least 1 year to really look effective. And don't say yes unless you're planning to follow through on things. The worst thing you can do is say yes and then not follow through. And then lastly, share experiences. If you've had adversity in your life, when you're applying, it's really important. I was in the admissions committee, not only for medical school, but I was on the admissions committee for residency, and I now interview people for fellowship as an attending. When I hear that they've had some adversity in their life and how they overcame it and how it made them stronger, it really resonates with me. That's probably one of the things that you remember the most from the interview trail, is just hearing human stories and what makes people human. All right, and that's it, basically. Just a few inspirational quotes. The second one is actually from me. I know how cheesy is that I included a quote from me, but at least I didn't put me at the bottom of it. And then lastly, yeah, just another plug. Follow me on social media. All right, if you guys have any questions, I'm here.
Thank you so much, Dr. de Latour. This was absolutely amazing. If you open up the chat right now, it's just exploding with all the praise.
Oh, cool. Praise.
I guess we can just do a couple of questions. I think everyone wanted to know, can hot Cheetos cause stomach ulcers?
No, they cannot.
Okay, we're glad to know that was a very common question. Another question that we had earlier on was, how closely do you work with other specialties in your field, like colorectal surgeons, other internal medicine? If you could kind of speak on that.
Oh my goodness, so close. I can't even tell you. Just yesterday, I was bragging to my fellow about how happy I am that the surgeons I work with are so stellar at NYU and at Bellevue specifically. If they weren't that good, my job would be so much harder. So like I say to people who are graduating from our fellowship, when you're looking for a job, make sure that it's not just a new endoscopy suite, that the surgeons there are good and that the radiologists there are good, that the interventional radiologists are good, because you are working hand in hand on the same patients and making multidisciplinary plans for these patients. And again, these are human beings on the line who are coming to you at their most vulnerable. So you want to trust your partners who are taking care of them with you. And then additionally, you know, if I can't do a procedure, I rely on IR to do those percutaneous drains I was talking about, or surgery. If like someone's colon is bleeding and it won't stop bleeding. I just did a procedure at like 1 a.m. last night. I'm so tired. I found the bleed, but if I hadn't, I would have called IR to do an angiogram to look under live x-ray, like where do you see the contrast spilling out of the vessels, or surgery to come take the colon out because no one can find it. But thankfully we found it. So that's I work so closely with them. Cell phone numbers, like we're besties.
Great, thank you so much for sharing that. We have some questions about pediatric GI and if that's something that you do or if that's something you have to go specialize in.
So pediatric GI is actually through pediatric residency. I don't take care of pediatric patients, but I will make exceptions. You know, most places you're credentialed 18 and over, but if I have like a 16-year-old, maybe even 15, if they're physically like an adult, I will scope them and take care of them because again, peds GI, the volume tends to be a little bit lower. So unless you're at like a major center that is specialized in like CHOP or something, right? A pediatric hospital, the patient, if they're physically like an adult, maybe better served by you if it's like a serious intervention. On the flip side, again, peds residency is a total separate entity and I don't take care of children ever, but my hat's off to them because it's so sad to see sick kids. I don't know, I couldn't handle it. I didn't do peds for a reason.
I definitely understand that. There are a lot of questions actually asking about any advice that you have about for women about having kids, you know, later in life and having those anxieties and just, you know, there's a lot of pressure on us as women, especially going to the medical field. And there's a lot of like talks about how it's just harder for us to do it.
Okay, I can speak. So I could talk your heads off about that. Okay, I got married when I was 30. I had my first baby at 31, and I just had my son when I was 34. Is that later in life? Sure. I'm from Buffalo, New York. A lot of people I went to high school with had their kids when they were in their early 20s, and their kids are like teenagers now. And I'm like, you know, like literally like changing diapers still. But to each his own, right? I wanted to go to graduate school, which you guys do too. And so it's just, you have to make a decision for what's right for you in life. Do I recommend that everyone do it my way versus the other way? No, you have to make a decision for what is perfect for you. I have had friends who had kids when they were in medical school, when they were in residency. I have friends who had like full grown children by the time they were in medical school because they had done like other careers and come back to medical school. So is it hard? Yeah, I think having kids is the most important, not the most important job, but like when you have kids, taking care of them is more important than your job, I think, right? Because if you're a mom, but not everybody wants to. So I have like, you know, nothing to say about like your life decisions in terms of what you choose to do for yourself, but it's really, really hard to balance both. Yes. Is it worth it? Is it the most fulfilling thing I've ever done in my life, balancing these two things? Yes. And it's awesome. You just need to have a good support system. And there's no perfect timing. It's never easy to have a kid. There's no perfect timing. I don't recommend, you know, if you're ready to do it, waiting because of your careers at X, Y, and Z. You should find a atmosphere where people are supportive of you work-wise, that they support you through it. Were people over the moon that I went on maternity leave twice? No. Are they going to say it to my face? They better not, because then I'll sue them. Right? If you want me to propagate society and you have wives and daughters, but you're not going to support me in having my family, then honestly, screw you. That's how I feel. So I empower women to fulfill their wildest dreams, and men, really, you should do everything that you want to do, because at the end of the day, your career isn't going to keep you warm at night. Your family is, and it's just very important that you do you. But you need to have people who support you at work, so that it's not more miserable than it needs to be. I'm fortunate in that I do have that. But you know, it's never easy. When you leave for maternity leave and you come back, people forget how great you were sometimes. And I was definitely marginalized a little bit when I came back, but then I reminded them, like, this is what's up. I am who I am. And then they were real quick to remember. So you have to be fierce. You have to be pushy. You have to be aggressive as a woman in a workplace, especially in a male dominated field. But it's possible. If you come in with the right attitude, anything is possible. And if anybody wants to talk to me more about this, like, again, I could talk your guys' heads off. You'd be so bored. So I'll do it.
Thank you so much. That was very inspiring. We all love that. Yeah, it's definitely inspirational. I guess on our last question, and kind of more somber note, there was, at the beginning, a lot of people were asking if you've seen any lasting GI effects due to COVID, or if there's something, or that's something that you expect to see in the coming months, years.
Okay, so COVID, as you all know, is a rapidly evolving field. What we've seen in terms of GI side effects for COVID in real time is that they bleed like stink. They bleed really, really badly, and it's hard to control these bleeds sometimes. You know, it can really manifest in any way, like pancreatitis, diarrhea, but I have not seen any patients with lingering GI issues yet. But, you know, again, we're less than a year out of the initial surge, and unfortunately, people are still getting sick. So, I mean, we'll see, but I haven't personally seen anybody with lingering, ongoing issues like chronic GI issues from COVID, thankfully. Other issues, yes, right? Like long haulers are having a lot of issues, ongoing shortness of breath, stuff like that. It's rough. Just, you know, when you're on the wards, if you guys rotate at all in the hospitals, just keep yourself safe.
Great. Thank you so much for answering that. And I think we'll go ahead and end for today. But your Instagram's there, so everyone go follow Dr. de Latour and ask her any questions you might have.
Yeah, I'll be happy to talk to you on the gram, but you just have to follow me. That's the price you have to pay.
Totally worth it.
We hope you have